Good morning, everyone. I want to thank you all for joining us. My name is Stanley Atkins II. I'm known as the Canamedic, and I'm the Georgia Chapter Director of Minorities for Medical Marijuana. Today, we're going to be having the Minorities for Medical Marijuana Health is Wellness webinar. And today, we will be joined by the renowned Dr. Marion McNabb, who is one of my esteemed colleagues. So, the Health is Wellness series is a series developed by Minorities for Medical Marijuana to really broadcast and showcase the different aspects of the medical cannabis industry. It is not designed to pay too much information on one specific disease process or program, but instead we want to encompass all of the medical programs around the country and internationally. So today I'd like to introduce my guest, Dr. Marion McNabb. Dr. Marion McNabb is the president of the Cannabis Center of Excellence Incorporated, a 501c3 nonprofit organization that conducts citizen science-focused population studies and programs in the areas of community engagement, medical cannabis, adult use cannabis, and social justice in the cannabis industry. The CCOE serves as a virtual resource and network of cannabis industry professionals, academics, policymakers, healthcare providers, consumers, and patients who aim to break the stigma over social justice in the cannabis industry. The CCOE Incorporated is currently running a COVID-19 medical cannabis patient study and consumer study. Dr. Mary McNabb is the former CEO and co-founder of the Cannabis Community Care Research Network, or C3RN, a Massachusetts-based cannabis research company from 2018 to 2020 that aimed to improve the evidence base related to medical cannabis therapies. C3RN with UMass Dartmouth led a 2-year open cannabis consumer and patient research study to assess the impact on health, social, and economic outcomes. C3RN also led a veterans health and medical cannabis study with UMass Dartmouth and partners. C3RN was an approved qualified training vendor for Massachusetts Cannabis Control Commission's Society Equity Program. Dr. McNabb also holds over 15 years of global health experience working in areas of digital health, HIV, AIDS, maternal child health, family planning, working primarily in Africa and Haiti. She received her doctorate of PH of Public Health from Boston University School of Public Health and her MPH from Johns Hopkins University School of Public Health. So, good morning and welcome, Dr. McNabb.
Thank you, Stanley. Thank you so Thank you so much for a kind introduction. I'm so excited to be here today and to be talking with you and working with you. It's a very kind introduction.
Well, it's great to have you. I knew when we were going to do this event, I was very excited. And the first thing that came to my mind was, how can we talk about research and data? And you were the first person that came to mind. So thank you. And thank everyone who's in attendance. Please share this video and be sure to subscribe. So we're going to get into it, Dr. McNabb. I know we have some great questions. I have some great questions for you today. So first of all, tell us, where are you from and what are some things that we should know about Dr. Marion McNabb?
Well, thank you. Yeah, so I grew up in Georgia. I grew up in the South. I was born in Oklahoma and then moved to Georgia and lived in Atlanta for my high school years. And then I moved to go to school and first in New Orleans and then in North Carolina. And then I decided to take a break from undergraduate and actually go to Zimbabwe. So I ended up going to Zimbabwe for a couple of months and then decided that I was going to complete my degree again, in my undergraduate degree. So I moved to St. Louis University and finished my undergraduate there and went to St. Louis University, created my own degree of African and African American studies because I was quite interested in understanding the history of what happened in Africa and colonization and, racial justice. So I studied that and then proceeded to move to Ethiopia. And I lived in Ethiopia for about 8 years until I started my doctorate at Boston University. So now here I am in East Boston working on cannabis research.
Wow. So I see that your work has taken you on some travels in your career. So my next question is, what was your motivation to enter the field of public health?
It's a really good question. So when I actually traveled to Zimbabwe, what I was doing was volunteering at a orphanage there. So there's about 300 children that we were teaching and taking care of, and being part of the caretaker community. Some of those children were disabled, but also some of them were orphans and had other health conditions. And actually, I was extremely curious because there was two children there. One was named Definite and one was named Doubt, and they were twins. And they were about 7 or 8 years old. I was probably 21, 22 years old. And the nurses there let us know as the volunteers that they were HIV positive. But there was nothing that they could do, and they couldn't tell the children they were HIV positive. But they knew they were HIV positive, and they couldn't tell them because they didn't have a rapid test or a test to identify HIV at that time in Zimbabwe. And so I was like shocked. HIV was growing around the world and specifically in Africa. And so we were told to care for these kids in a different way, right? We still obviously care for them, but be aware that, they had HIV. By the time that I had completed my volunteer time there, Doubt died and Definite lived. And we came to understand that Definite did not have HIV, but Doubt did. And I was like, what is going on here? How can you be twins? And how can one have HIV and one not have HIV? It's like, I don't understand this. So I decided that I wanted to learn about this. And I wanted to learn about why this was happening and why there were disproportionately, why is HIV spreading so rapidly in Africa, and what can we do to address this, right? Or where I was in Zimbabwe, and I wanted to learn about it. So that's when I moved back to St. Louis, and I studied African American studies. But originally, I wanted to be a physician's assistant, and they had a program at SLU that was for physician's assistants. So I was going to be a clinician. I wanted to be a doctor, like a medical doctor. And so when I got to SLU and then they removed the program, I decided, instead, let me just study African American studies and understand why is Africa, why does this poverty exist? And why do these disparities exist? So I studied that. And then when I finished my degree and I decided my father works in public health, global public health, and he's the one that helped me sort of get to Zimbabwe. It was his colleagues. And so I decided, I want to go back to Africa somewhere. But I was interested in also Jamaica too. I have a big love for reggae and Rastafarianism and understanding that culture too. Kind of ties in with the cannabis. But I was like, do I want to go to Jamaica? Do I want to go to Zimbabwe? Do I want to go to Ghana? Or do I want to go to Ethiopia? All places that also tie into that culture. And so I decided, my dad had a colleague in Ethiopia. So I said, okay, I'm going to go to Ethiopia and I'm going to try and volunteer and see what I want to do and see if I want to be a doctor or see if I want to do public health. Let me see what's going on. So I had the really fortunate opportunity of being able to stay with the director of CDC in Ethiopia while I was there, and started to learn about public health and the importance of population level interventions and looking at population level trends to help drive medicine and drive clinical care. So I just got hooked, and I ended up staying in Ethiopia for 8 years. And working on HIV/AIDS programs with U.S. government PEPFAR funding. So CDC had some projects, USAID had some projects, and at the end I was working on with Johns Hopkins on a project with 122 hospitals in the country, working on a comprehensive HIV/AIDS care, prevention care, and treatment program, including TB, multi-drug resistant tuberculosis lab. Research studies at that clinical, very high level. We were looking at diagnostic tests for HIV testing, acute HIV testing. So I was working on research studies related to that, set up a multi-drug resistant tuberculosis lab. I learned a lot about how does a country and a people and a culture deal with the onset of a really horrifying illness. At that time, there was no real, treatment we were trying to find it, right? So went from watching people die without having a test available to even see if they had HIV, and the whole care was palliative care, to prevention, and watching a country go from having to implement a new way of dealing with patients was fascinating. And I think there's a lot that we can take on and learn lessons from that, and actually for cannabis and introducing cannabis. And we could talk more about that. It's a little provocative, but I think there is a lot of lessons we can learn from how we dealt and how we addressed HIV epidemic to now. Sorry, it's a long-winded answer, but that's how I got into public health.
Well, thank you so much. That is some amazing information to see your research base in studying abroad, and as comparing that to some of the health disparities and health inequities as they face here in America. That's very important. And I see we have some comment. There's a comment from Dr. Felicia Dawson that says she'd be curious to know what she found out regarding why HIV spread so quickly in Africa, and why, in your opinion, is poverty so widespread. So it looks like we're going to need to do a follow-up to this.
Yeah, I feel like I could talk for years.
We had some great discussions on that.
About it. Yeah, those are two very important questions. So I think some of the reasons that HIV spread so quickly in Africa, well, one, I think poverty. I think addition, like I said before, the testing and the treatment and everything was a little late to the game for Africa in some ways. So because when the treatment started to come out, the drugs were extremely expensive. And so there was a lot of international negotiation because the drug companies wanted to charge massive amounts of money for this, right? And, poorer countries can't afford it, but that's where the disease burden was. So there was this huge international debate, and it was like people like Bono were involved. Bill Clinton, the Clinton Foundation did a lot of negotiation with drug companies to lower the prices of drugs so that the access could be available. So other reasons why HIV spread from a population perspective was, sex worker trucker routes as well. So a lot of interventions around trying to ensure testing and treatment is available. And a lot of, there's specifically like in South Africa, this was actually really awful. The diamond industry and the mining industry is horrific in some ways, and really fueled a lot of the spread of HIV in Southern Africa, unfortunately. And so there's, a really undue burden in certain communities, of transmission. And I think that, in poverty, that one I'll just have to talk about another time, but I would love to talk with you, Dr. Bass, about it. Continue to talk about it.
Thank you.
Yeah.
So question. So from your experience, what are some of the long-term benefits from medical cannabis research, and how does this research truly benefit the cannabis industry?
Yeah, so the benefits of long-term research and how does it impact the industry. So there's been a lot of research studies that have happened with cannabis and with medical cannabis. A lot of those studies are at a preclinical level, and a lot of the clinical level studies are in Canada and Israel and other countries, not in the United States, because of our federal restrictions and the limitations for researchers. So currently, because cannabis is federally legal, Schedule 1, you have to go through a pretty arduous process to get approved to do a clinical cannabis research study in the United States. And it's lengthy, you go through the National Institute of Drug Abuse, and you get access to medical cannabis from one producer, University of Mississippi, that you can use in clinical trials. Now that cannabis is not representative of what is out there legally on the market and people are consuming. And the process to actually become licensed and to do that entire research, which is a typical normal research process in the United States for an academic or a clinician, it's very hard. And it's there's not a lot of funding that is aimed towards showing the long-term medical benefits. I think we're starting to see more funding come out now, but traditionally in the past, the studies that were funded through NIDA were funded to show harms related to cannabis. And a recent publication a couple months ago came out documenting how much money has been spent globally on studying cannabis and what were the aims of those studies. So I think, the long-term benefits of studying cannabis, it's already here. People are consuming it. This is a 3,000-year-old medication. People are using it and they're finding real value in it. And the reason why we chose 3 or 4 years ago to approach cannabis research in the United States as a citizen science focused and a population level approach initially is to understand what people are doing. What are people consuming? Why are they consuming it? What kinds of relief are they finding with it? And then once you start to understand those trends, you can then move into deeper clinical trials, or spend the big dollars on the large clinical trials cost a lot of money, right? So you really want to make sure you've got some data, population level data, or trend label to back up your clinical trial, right? And so we started that way. I actually was approached by UMass Dartmouth, and about 3 years ago now. We have been advocating very significantly for a cannabis research license in Massachusetts, and for Massachusetts to allow cannabis to fund cannabis research. So UMass Dartmouth approached me as we were, advocating publicly around this, and reached out and said, "I'd like to partner with you on conducting cannabis research studies, as long as they're anonymous and you're not collecting personal identifying information. Let's go." And so we started with the open cannabis consumer and patient study, and then we followed with the Veterans Health and Medical Cannabis study, now with the COVID-19 study, and the new study that we're about to launch as well. Really excited about. So I think the long-term benefits of cannabis research for the industry, the industry, great, you can sell cannabis and make a profit, and that's what a business is supposed to do, right? However, this is not just a product. There's medicinal benefits to it. There's cultural benefits to it. There's chronic conditions that people are consuming this for. So it's not just a one and done, so to speak, right? So this is something also that is so important to understand, is that with the data that we're finding in our studies, people are finding significant relief using medical cannabis, and oftentimes preferring it over prescription or over-the-counter medications. And this is where we need to involve our clinical community. This is really important. You can't just take somebody off of a Suboxone and give them cannabis. You need to have a clinical package around it, and education around it. And I think the industry needs to understand that. And I think they do. There's some players in the industry that really deeply care about the medical side, and also about the adult use side. But I think it's imperative for the industry to invest in also research, and not locking these things up in the pharmaceutical market, if that makes sense.
That makes perfect sense. I was recently on a research panel, and one thing that we have to discuss as caregivers, as clinicians, as researchers, is that the integrated cannabis as a medicinal therapy is a polypharmacy approach. So you can't just take a patient off their benzodiazepines, their blood pressure regulators, or even something for the endocrine system, and just say, hey, cannabis is the end all be all. Because as you said, with Suboxone and Duloxetine or the other medications, there needs to be a process, and clinicians and caregivers are going to have to intertwine. I know oftentimes different physicians don't talk to other physicians. So the doctor managing your blood pressure may not talk to the doctors managing your blood sugar. So there needs to be a polypharmacy approach, and this research is something that I think that could really boost that. So going back to research, what are some of the barriers that currently limit medical cannabis research studies? I saw that you notated financials, money. It takes money to do research because you have to pay clinicians. But what are some additional barriers that you've seen that are, keeping us from gaining the research that's really needed to push this industry forward?
Yeah, so again, funding definitely is always a barrier. There's not traditional grant funds right now. Hopefully there will be in the future. There are some little pots of money that you can apply to, but they're just not like, hey, I want to study HIV, right? There's a lot of funding resources around there. So I think another barrier is, when you're currently conducting a study. So like my mentor and dear colleague, is Dr. Stacy Gruber, and she's been doing at Harvard. She's been doing research on medical cannabis, approved by NIDA, and officially for quite a while. One of the things that you can't do is you can't say, here's your medication and here's your dose. You cannot, as a researcher, right now, right? I mean, under the licensure, and every state's different, and you can do certain studies in certain states and it's not federally legal, right? So and also the traditional ways that we have believed as gold science or gold standards in science for research, the clinical trial and the phase process, we have to be really creative around that, because cannabis is not a single molecule drug, and it's whole plant medicine, and the combinations of the whole plant. I mean, you can get distillate if you want, right? But I believe whole plant medicine is in the combinations of your entourage effect and the different terpene profiles and cannabinoid profiles all interact differently by different people and different conditions. And so if we're really going to say, hey, Blue Dream in Georgia is helping me with my chronic pain, but that same Blue Dream in Missouri may not be the same Blue Dream. And it's such a personalized medicine that we have to think out of the box about how we study it. That's just, we just got to, I think. And I think we can really push the envelope on what we believe as really good, solid methods too, and really start to engage patients. Back to your point earlier, polypharmacy. This is a disconnected health system, right? You have a doctor for this, a cardiologist for this. Take your example, the VA. You've got VA care, and then right? It's so disjointed that I think the paradigm of medicine should be focused on empowering the patient themselves to know and to be able to manage it. Because if the system's broken around it, we need to know ourselves, right? So let's educate the public. Let's educate people. Let's also educate the healthcare providers. Let's also educate the researchers. It was funny. I graduated from BU, School of Public Health, and I attended an event on medical cannabis at BU School of Public Health. And it was an interesting event, because when you bring cannabis researchers together, you might have polar views. Sometimes people come in the middle, but you've got pretty, two-sided. They're pretty. I don't know, how would you say? You know what I'm saying? Polarized, right? So I'm sitting at this dinner, and there's I can understand the other researchers' perspective. I went to school at this school, and they were pain management researchers and doctors and addiction specialists, and I'm like trying to be like, hey, do you know about medical cannabis? I heard a study in Israel last year, here's some of the findings, and they didn't have any idea. And they have a very polar opposite view. So it's just a very interesting, obviously great academic discussion. It was a great dinner we had afterwards, and it was awesome. I'm all about talking about these difficult things, but it's just to say that I think we might blame our healthcare providers and our researchers a little too much, because the education around this was removed out of our medical education system. The endocannabinoid system and understanding how cannabis works in the body was removed out of medical education. So we can't blame them too much. We just got to put it back in there. You know what I mean? And kind of change the narrative around what we're talking about with polypharmacy and with harm reduction and how we're addressing this. I mean, cannabis is a non-lethal substance, and compared to some of the other drugs that many in our studies are reporting they're reducing the use of, like 71% in our first study with over 2,000 people. Over 70% of our veterans report using cannabis to reduce the use. And in COVID, it's around 50% in our COVID study. So I think it's an important issue.
Thank you so much. And for all the viewers out there, I really want you to pay attention to some of these things, because we've got some questions that came in. One was, how can they participate? We're going to get to that one, so stay tuned later in this episode. And real quickly, I see that we had a question that was asking, what can nurses do to try to empower their patients in regards to chronic pain and the potential efficacy of using medical cannabis?
Yeah, I think nurses are kind of the key population in healthcare, one. thank you for all of your work, nurses. You know your patients really well. I think chronic pain is awful, right? I mean, people that live with chronic pain, quality of life is just, it's rough, right? You're constantly having to battle with pain and then trying to be happy, but how can you be happy when you're constantly in pain, but then you're like, I'm trying to live life. So I think for nurses, showing that medical cannabis is an option, and also being educated yourself about the benefits. So the benefits, the ways you can ingest, and counseling approaches. Because one thing that I've found when people are curious about it and they, go out and they'll buy a bunch of different types of products and try it, and then maybe they're going to eat an edible and they're going to eat too much of it, and then they're going to be like, boom, I'm done. And you just lost like somebody who could have such great potential if they would only eat 5 milligrams, not the 30, and so patient education around how to consume, what to happen if you feel like you consume too much. There are things you can do. You can crush cracked pepper, so there's very easy ways to counsel patients. And, I think just also being there for them when they're trying something new. When somebody's trying something new, it's always good to have like a mentor, like, hey, is this okay? Or like, can I ask you advice? Like, when it comes to dabbing, I mean, people like somebody doesn't even know what a dab is. But it can be very intimidating, but it also could be very helpful for your health if you have the dialed in terpene and and you have a health condition where you need, a high potency. So, but dabbing can be very scary. I mean, I'm still scared of it, but I dab. You know what I mean? So,
Yes.
And what your thoughts as well, Stan?
I agree. Because oftentimes consumers or even some of the kind of curious are intimidated by the entire medical spectrum. So sometimes a physician may be a little bit intimidating. Having that conversation with a nurse may even be a more gentle approach, maybe a little bit more personable, because as you said, they know their patients. And this is going to be very important. Myself, my background is as a paramedic, and I tell people all the time, what really has been my strongest tool in my medical cannabis journey was my knowledge base in emergency medicine and healthcare, along with anatomy and physiology, and understanding how those tie into it when it comes to medical cannabis and alternative therapies. I saw that Dr. Felicia Dawson put in the comment, the cannabis nurses, a resource for cannabis nurses, and also the veteran studies, which leads us into my next question. In 2019, you and your team did a veterans medical cannabis research study. What was some of the results of that study that you gathered? I was a participant in that study. So tell viewers, what was some of the data that was gathered from that research that was conducted?
Yeah, thank you. And thank you so much for the support for that study. We really appreciated the outreach. So the 2019 Veterans Health and Medical Cannabis Study was a partnership with Stephen Mandile, who is a leading veteran advocate in Massachusetts. He reached out to us to launch that study in 2019. And so together we worked with UMass Dartmouth, developed a Veterans Health and Medical Cannabis Anonymous survey, and worked also with Dr. Stacy Gruber at Harvard. She gave some input. She's been working, runs a veterans medical cannabis study right now as well. And we also connected with Ann Brum, a joint venture and co, who helped us on the community engagement side of the project, which was a cannabis advancement series. We ran a couple of 6 events that brought together veterans, and we presented some of the data and brought some of the leading researchers and experts, including Dr. Sue Sicily, Dr. Sulak, Dr. Stacy Gruber, and different commissioners at the Cannabis Control Commission in Massachusetts, IAVA, DAV, veterans organizations participated. It was a real, amazing project that we worked on. I think it was very impactful. We designed the study to, one, collect anonymous information from veterans about the medical conditions that they're currently facing, and then the traditional medications or conventional medications that they're taking, and then ask them if they consume cannabis. If so, for what health conditions did they find relief, and, how did it impact the quality of their life? And so we had collected a total of, just 1 second, sorry. I'm just going to pull up the results here. So we collected a total of, excuse me one second. So we also worked together with several different cannabis industry partners in Massachusetts to get the word out, and then also worked with you, Stanley, in Georgia to get the word out. So we basically collected 562 veterans, filled out the complete survey. And about half of those veterans were above the age of 50 years. So really interesting. We had a majority male population, so not a lot of females. And it was 79% white, 6% Latino, and 4% African American. So not that great of a diverse representation. We had basically, when we asked what are the top health conditions that veterans are facing, 38% said chronic pain was their top condition, 25% said PTSD, and 9% said anxiety. When we asked about PTSD specifically, 25% said that PTSD was their number one condition. And out of those that said that, 75% scored a PTSD positive scale that we asked. So confirming that, in fact, 75% of those would have been verified as PTSD by the VA. So when we asked them, how much money are you spending per month out of pocket for your medications? They reported, spending about $100, $98 out of pocket for their current medications and taking an average of 4.1 medications a day. That's lower than what other studies have reported. And those medications, when I say 4.1, is that's an average. Okay, so there's wider range. We have people taking upwards of 50 a day. So we asked, do you have medications in your house that you'd like to get rid of? 30% said yes. And 56% said they get their drugs mailed by the VA. Now, when we ask, are you consuming, do you consume cannabis? 92% of our sample said yes. So, yeah. And probably because it was a Veterans Health and Medical Cannabis study, right? So that was the frame of it. So again, this is the population we're using. We understand convenient sampling and all of the limitations around that, but we're just trying to understand what people are doing, right? And why people are consuming, and so that we can do more good research based on that and get care out to people. So again, we ask, okay, if you're using medical cannabis, what's the primary conditions that you're using medical cannabis for? And it follows a similar trends. Chronic pain, 37%, PTSD, 25%, and then 11% anxiety. Now, when we ask symptoms that, medical cannabis is helpful for, 57% reported, we said, select all these symptoms. Which ones is most helpful, cannabis is most helpful for? Sleep and insomnia at 57, pain at 56, depression and mood at 52, anxiety at 48, aggression at 26. When we ask side effects, number one, dry mouth, 68%. Number two, increased energy, 35%. Changes in appetite, 35%. More or less talkative. Thankfully, these are not overdoses. And again, back to the point of how many are using medical cannabis as an alternative, 78% of our veterans are trying to use medical cannabis to reduce the use of unwanted over-the-counter prescription meds. So, the other key data point that we found, I mentioned veterans spend $98 out of pocket for their prescription medications. They spend $343 out of pocket every month for their medical cannabis, and that's not covered by insurance. And this population is, out of our results, about half of them are 100% disabled. So, income, this is a real issue. Right? You've got a chronically sick population that, is relying on the VA for health services, yet they're finding relief from medical cannabis, yet they're spending this much money. How can they afford it? This is the problem. How can patients afford this medicine? You need to have health insurance coverage, but that's a whole nother study we'll do. And then finally, the barriers reported is 51% money to purchase the right products, 41% access to the right products, and 32% money required to get a medical cannabis card. So
Well,
And
thank
so,
you so much for that. And for everyone who's watching this, if you're a veteran, if you're a non-veteran, these types of these programs are very important because when they ask, why do veterans need access to medical cannabis? The discussion is being had at VAs across the nation in regards to, how can the VA engage in medical cannabis, being that it's a government-run entity. So that's one of the biggest barrier, guys. And what they say is we need more evidence. We need more evidence. We need more data. And programs like this will really help and truly boost it going forward. And also, creating that comprehensive data for us to go back and reflect upon as we move forward. So that leads me to my next question, Dr. McNabb. So I know that really quickly, what was your interest that drew you into the Georgia market and helping Georgia patients gain access to medical cannabis?
Yeah, good question. I'm really excited that I have been working in Georgia for the last year. I'm working together with you with a company called Georgia Atlas, and we've applied for a medical cannabis or a low THC oil license in Georgia, and I'm honored to be director of research with them, and also to under the leadership of Dr. James Smith, who is he's our chief medical officer and has been very, very engaged in medical cannabis advocacy and work in Georgia. His daughter has intractable seizures that have benefited from the use of CBD, and he's our fearless leader. I started working with them about a year ago, and hit the medical board that has been established under the leadership of Dr. James Smith is quite impressive and very excited. One of the members is Dr. Lisa Perry Gilks, who's the current president of the Medical Association of Georgia, followed by Dr. Andrew Reisman, who's the previous president of the Medical Association of Georgia, and Dr. Sarah Benson, who is a child psychiatrist and psychologist at L'Oreal Psych Group and also at Morehouse School of Medicine. So those are the medical board, and excited to work with minorities for medical marijuana. It drew me to work in Georgia because I'm from Georgia. I grew up in Georgia. I had friends that were arrested for cannabis in Georgia when I grew up. I saw people being incarcerated for cannabis. I got a love for the Peach State. I still have my 404 number. So I'm really excited because I think there's a lot of work that we can do in my home state of Georgia and your home state of Georgia. And really excited to launch a research study together with you. And maybe we could talk a little bit more about that.
So that leads us right into my next question. So what can you tell us about the upcoming Georgia medical cannabis patients and veterans research study that we'll be launching? And how can anyone who's watching and people who get the updates, how can they participate in our upcoming research program?
Awesome. Yes, I'm really excited about this, and we could use all the help and input that anybody wants to give. So basically, we're launching a Georgia medical patients and veterans study. Together, Stanley Atkins is my co-PI, I'm going to say, and we're together with a number of other colleagues, and we'll be reaching out to folks that have we've been talking to for a couple of months now, also to engage in giving input on this research study. So it's going to be an anonymous survey of medical patients and veterans in Georgia. You don't have to be a consumer of cannabis to take this study. We're going to launch it on April 15th, so data collection will begin then. Right now, if you have ideas or you want to, input some questions into this study, send them to Stanley and myself. We're open to this. We want to make this research study helpful for medical patients and veterans and for the state of Georgia and for everybody to have an awareness about what's happening around medical patients and veterans and their interest around low THC oil. Again, data collection will start on April 15th. Anybody, if you want to know, you want to include a question or want to include a data point, again, reach out and let us know. I don't know if you want to expand upon it a little bit more, Stanley, about
yes.
the study.
So So everyone who's watching, this program that we're launching is going to be very important. I've been asked by Dr. McNabb to join her in this research program, and it's going to be imperative that we get as many of you in this program as possible, because the data that we collect is going to help us see how we can improve the current program here in Georgia, because Georgia has an infantile program, which means it's at its beginning stages. So we need to ensure that from the inception of this program that we've got data. If you guys want to expand our program, if you want a better program, the politicians are going to ask for data. What is the comprehensive data that you have? And I know that we can get a lot of patients, a lot of caregivers to come down and give their personal experience, and we genuinely appreciate that. But in regards to legislative policy, they call that anecdotal, and they want something that has been clinical. So these data programs are going to help us see what we're doing here in Georgia, but also grow the program, because this data is going to help us understand how can we help fix the holes that we have, but also help other programs expand. So Dr. McNabb, my next question is, once we complete this data, how can the Georgia Medical Cannabis Research Program potentially assist other emerging markets? Because in the South, there are a lot of states that have eyes on Georgia currently. So what could the data from this program potentially help, and how could it help other emerging markets?
Yeah, that's a great question. And one of the keys about data use, and where I come from data use perspective, as we're collecting research information, I have always been frustrated at the time from data collection to the time of publication in a peer-reviewed journal. It could take about a year or even longer, right? And so that can lessen the importance of the findings in the present moment or in the near future, right? And the implications that it can have on health and access. So in the studies that I've done in the past and in this study, being able to rapidly analyze the information and get it back out to the public so that people can use it to improve access and improve patient care is a goal. So we're interested in, like I said, using the data to educate the community and let the community see the information and not just be locked up for researchers, if that makes sense. So I think this study for Georgia will be very beneficial for Georgia. We're share information with the state, with the legislature, with the Department of Public Health, whoever needs to see this, designed to help the program, but how can other states learn? I think, this type of approach is important even by state, because every state's different, right? Every state's culture is different. People are different. Their programs are different. Georgia is not the same as Alabama. It's not the same as South Carolina, but, there's a similar Southern culture, but it's different, right? Everywhere is a unique place. So I think it's important to study unique states. So I think taking this approach and lesson learned from Georgia, see what people, what we're going to report out, or, see how it works here in Georgia, and then see if that's going to be helpful for other states that are emerging in the South. I think there's a great opportunity in the South for education, for research, and just the impact of medical cannabis in general. So I'm excited that the South is embracing it.
Thank you so much. So I do have an additional question. We've got a couple more questions before we get ready to wrap up here. How can viewers participate in the upcoming program, and how will this program differ from the 2019 one? That was a question from Dr. Felicia Dawson.
Cool. You can participate by the research study going to georgiaatlas.com. Also, I think we'll work with Stanley and to have links and promotion out about the study and how you can take the survey. Additionally, so how it will be different from the COVID-19 study. So the COVID-19 study and
the 2019 study.
Okay, the 2019, the Veterans Health and Medical Cannabis Study. Yeah, so this is only going to be focused on Georgia, and we'll ask some of the questions like we did in the veteran study, but actually it'll be a little bit different, because what we want to look at is we want to see if people that maybe haven't even consumed cannabis at all will take the survey. So anybody could take the survey. Whereas the veteran study, we, as I reported, it was kind of very sort of targeted at medical cannabis, and a lot of the people that responded were medical cannabis consumers or our patients. So we're interested in trying to broadening the scope, and we're going to be asking different questions. So some questions that people are consuming low THC oil, but more around different questions around that are Georgia specific for the Georgia program, also the disease profiles that are in Georgia and the health conditions that Georgians most face. So it's just going to be much more tailored to the cultural realities and the health realities of Georgia.
Thank you so much for that clarification. I'm sure our viewers appreciated that too. So everyone, just to follow up on what she said, we are developing this research study specifically for the state of Georgia. The Canamedic was, very diligent in finding, teams to work with, and because we need research and you need a team of researchers behind you. So we have a team, and now it's time to do the research. So I have another question for you. If you, Dr. Mary McNabb, were in charge of oversight of the Georgia Medical Cannabis Program, what recommendations would you make in terms of expansion of our current existing program?
All right, good question. Well, first I would check with our medical board and Dr. James Smith, and really defer. We have a number of about 20 clinicians, healthcare physicians that are part of the medical board team at Georgia Atlas and under Dr. James Smith. So I would first check with them because they're definitely the experts. But what I would say is Georgia could, there's a really exciting opportunity for research in Georgia compared to other states because of the way that the law has been written and that allowing academic institutions to participate and sort of providing protections for them, which is incredible, right? So the challenges that I've faced in the North is that, academic institutions fear losing their federal funding. There's not really wanting to step into it. I partner with UMass Dartmouth, and there's a reason for that, So it's exciting that Georgia has embraced research so much and the medical focus. And this, I think, is going to set Georgia apart because, paying so much attention to the importance of medical cannabis and research, I really feel it in the state. I mean, I feel it when you read the legislature, when you talk to people. There's real commitment for medical. And that just to me is really exciting. I mean, I've been working in a medical market, but also a recreational market. And I'm like, man, what about the medical? What about the medical? And here Georgia's going to be, I'm pumped about it because there's so many things to learn and there's so many people to impact and there's so many patients to get access to this low THC oil to. So again, if I was also the head of the commission, with all due respect to the commission, I would, and to the state, I would really ensure that we had additional products available and that we really understand that medical cannabis is complex, like I said, and it requires different formulations and different types of products for different types of health conditions and then varying doses. And so it's not a one-size-fits-all type approach. So one thing is, I would love to see, a patient being able to access 100 milligram edible if they want to, I mean, that's something that people find benefit from. But also I'd make sure that, youth prevention is at the forefront of this, right? We're making sure that youth don't have access and, we're making sure all of our public health and public safety protocols are in place. I think the other thing that I would recommend to the commission also is just focus on social equity and social justice and, continue to keep that narrative going, and not only narrative, but work around that restorative justice is, I think, really important for us to address the negative impacts of the war on drugs and what that has done to Black and Brown communities and what that has done to Latino communities. And, I think we need to be, I would pay attention to it, but that's if I was the commissioner.
Thank you so much. Your sentiment really reflects some of my thoughts as well. The addition of more products, expansion of the access to products, because some patients with an oil or a tincture may not be suitable for their disease process, and that may not be their preferred method of consumption. I know down here in the South, we're still in the Bible Belt, so we got to make sure that if we're going to loosen that Bible Belt, I think the easiest way to do that is with topicals, at products that can be applied to the skin, transdermals, or even some of the transdermal patches for especially some of the elderly, as we combat, 50 to 60 years of the war on drugs. So, it's going to be a great opportunity right now for us to show patients and really educate the public. My thing is education, and I prefer a medical program. Adult use programs are great. I appreciate them, but more programs are needed for medical, because with the continuation of expansion of adult use programs, the continuation of legalization, we see the death of many medical programs, and the people who get caught up and left behind are the patients who truly need it. And I saw that Yolanda from the Georgia Medical Cannabis Society stated, one of the barriers to access is patients being able to financially afford it. Most patients that have long-term disease processes are also financially compromised in many cases. So if they're unable to have a normal quality of life, many of them are also unable to work a full-time job. So we have to understand that we're going to have patients here in Georgia that won't have the monetary means or the money to even access these products. And just because a patient doesn't have money should not be a barrier to them having a happy quality of life. So those are some things that we're going to have to work on. We've got about 7 minutes left, and this leads to my final question. So, Dr. McNabb, I like to eat very healthy, and I want to ask you, sliced avocados or French fries as a side item if you had to choose?
Great question. Excellent question. For me, I would definitely choose an avocado for many reasons. Go avocados! They're really healthy. They got a lot of magnesium, I think, in them too. They're tasty. You can make guacamole with them. In Ethiopia, they actually drink avocado smoothies. Yeah, so I've had a smoothie with avocado in it before. Definitely an avocado, absolutely. What would be your choice?
Avocados.
Nice.
I eat avocados every day, so I always ask people, because some people have a thing against avocados. So I would like to ask people, would you take French fries or the avocados? So thank you so much. And so for
my favorite way to have an avocado, actually, I think I'm probably going to make this now that you've asked me, is slice an avocado, and then you put tomato, onion, and balsamic, and a little bit of vinegar, and make a little salad where the pit is, and then you're just eating a little avocado salad. I'm gonna make one.
Absolutely, it sounds like one of the dishes they have at Chateau Elan, the avocado toast. So guys, don't forget to eat your avocado. They've got natural oils and fats and plenty of vitamins and minerals for you. So Dr. McNabb, before we get ready to wrap up, I know we could go all day. Tell us how people can follow you and how can they get in touch with you?
Oh, cool. Yeah. So visit Cannabis Center of Excellence, Inc. So it's www.cannacenterofexcellence.org. You can sign up for our email listserv. We're about to do a big web rehaul. So, stay tuned for a cool new website coming, but you can find a lot of our data there. You can download the publication, Cannabis Patient Care magazine that we launched last year with the veteran study. So it has all the data in there. You can find, I'll be uploading in the next week or so, if you stay tuned to that website, more data, more information that you can download, more videos of events that we've done in the past with cool educational content. You can also follow me on LinkedIn, Marion McNabb, LinkedIn. You can also visit Georgia Atlas at www.georgiaatlas.com. And we'll be announcing there more around the research study. And yeah, stay tuned for April when we launch, and we'd love any support, any help. Fill out the study. There'll be some incentives to do so as well. So we'll try and make it fun, collaborative, and like I said, if anybody's interested in knowing or wanting to include a question or two in this study in Georgia, feel free. Reach out to Stanley and myself. We want to make this an engaging and empowering and impactful. So, that's
Thank you.
I'm also on Facebook too, and you can follow us on the nonprofit on Facebook, Twitter, Instagram, and LinkedIn.
Thank you so much, Dr. McNabb. We're getting ready to wind down, everyone. Thank you all for attending. Dr. Mary McNabb is a current member of the Georgia chapter of Minorities for Medical Marijuana. So if you don't know, Minorities for Medical Marijuana is a nonprofit based out of Florida. The founder, Roz McCarthy, has worked to expand our programming to over 28 different states, the Caribbean, and London. So, guys, whatever state you're in, be sure to see if we have a M for MM chapter. If we don't, you could reach out and see if you're interested in following us and starting a chapter. So, again, my name is Stanley Atkins II. You're a Canamedic, and thank you for joining us for the Minorities for Medical Marijuana Health is Wellness series. Have a great day, everyone, and more updates to come soon.
Thank you. Thanks, Stanley.
Thank you, Dr. Brad. Have a great one.
I can't let nobody keep me from reaching the top. Don't you give up on nothing.